Welcome to ICE Webinars, a cool place for hot topics. ICE Magazine is proud to bring our new monthly webinar series to the imaging industry. ICE is the community that directly links nearly 7,000 imaging professionals with a monthly magazine, online community, annual conference, and now a monthly webinar series. We'd also like to invite you to ICE 2021. The Imaging Conference and Expo is the only conference dedicated to imaging directors, radiology administrators, and imaging engineers from hospital imaging departments, freestanding imaging centers, and group practices. ICE offers valuable continuing education credits from SRT and ACI, pending approval, and keeping in line with our successful conferences in the past, offers comprehensive educational opportunities for attendees. Please visit attendice.com for more details. We are excited about today's presentation featuring Ken Fazzino, Senior Director of Envision Physician Services. Today's webinar is eligible for one ARRT Category A Continuing Education Credit by AHRA, and is approved for one CRA credit. You can obtain your CE certificate by completing the post-webinar survey. More details on this at the end of today's webinar. As I mentioned earlier, our presenter today is Ken Fazzino. As a Senior Practice Director, he is responsible for the business aspects of radiologists on site at numerous hospitals. Accountable for each site's profit and loss, practice management, radiologist workflow, scheduling, and consultation on department workflow. In today's presentation, Ken will discuss the Imaging Informatics subspecialty of radiology that is designed to improve the efficiency, accuracy, and reliability of radiologic services within the medical enterprise. Ken, you may begin whenever you are ready.
Thank you, Jen. Thanks for having me, and thank you to ICE for having me as part of the presentation today on the agenda. What I want to do today is cover a topic that I found very useful back in the day when I first moved into the IT world from imaging. I'm a radiology technologist by trade, and back in Y2K, when the world was about to end, we were thrust into doing these projects with IT, and I did not have the background that I do today, and I found it would be very helpful to help provide current leaders, emerging leaders, and some of the IT, if you're IT or operational in the clinical sense, some information that kind of bridges the gap. So hopefully by the end of today, you'll have a little bit better understanding of some of the terminology that's used in the projects, how to get it, who to go to, and most importantly, if you're the imaging leader and you're running these IT projects, you're not expected to be the expert in all these realms. You just need to know where to find the information, how to get it. So to go through these slides, I'm going to turn off my camera. I'll turn it back on at the end of the presentation, but I'd rather you focus and pay attention to the slides. So I'm going to turn that off at the moment. And here we go. So today we're going to talk about a number of topics. Whoop, sorry, wrong button. Let me get to that. All right, why IT is critical. The early days, imaging-related components in IT, benefits from IT and imaging, workflow improvements, radiology connectivity, relevance of managing projects, and a little bit of the now and the future and where things are going. One of the most important things in our world today, clinically, quality is at the top of the list. There is a very unique challenge to blend quality and quantity. And quality starts at the top. What that means is it has to be driven from the C-suite or leadership down. If quality isn't embraced by leadership, then it's hard to hold accountable anybody following that leader. The aspiration to excellence has to be formalized. It has to be something that's actually written. It has to be targets. It should be a vision that's shared, but it is a formal program. It's not something that is just loosely talked about. It has to be measurable and something in hard press, basically. Accountability is universal. When you put IT into the mix, Accountability for the quality comes across from everybody involved. So it's no longer just a leader, the manager, the director. Everybody now has a piece of the quality and its outcomes. Quality is reported accurately. What the systems now do is take away the manual piece that we used to have years ago, obviously with tick sheets and collections of pieces of paper or flashcards or whatever it is that you collected back in the day. And now it is in a accurate measurement because it's data-driven, it's computer-based. Quality is measured and has actions. We now take that same measurement, and for all of you who've gone through quality improvements, this data that you're going to get or the connectivity helps support those actions and has outcomes. Quality is hardwired through IT. Because everybody is now using the systems, it's more of a hardwired system. It's not back again using the flashcard example from years ago. If you forgot to do the flashcard, you forgot to do it. And you may have tried to collect 100, but you actually only collected 30 of them. Here, if it's hardwired, such as your steps within a RIS system, your radiology information system, you're complete in your steps that you're doing for the patients, it has to be done. So it's hardwired, and that helps build that quality. Finance and quality are unified. The outcomes of your finance team, your billing, your collectibles, the report input, the report information, all of this quality is now tied to finance. And we'll see later in the slides of these initiatives over the last few years that are now tying dollars and cents to your qualities in your reporting. Clinicians are engaged in QI daily. If the right programs are in place, the doctors are now doing peer review or review of their own or their peers on a daily basis in their normal workflow. It used to be, again, a manual process that you'd have to pull things and set things up. Now it's hardwired within the programs themselves. Quality function is best in class. It is really being used to brag about your quality steps and your initiatives. You want to be best in class. That's going to be what helps draw attention to your centers, your sites, and helps gain more business from your outlying physicians and internals. And decisions are based on data, not emotion. This is the most important one to me in here. The rest are all the business pieces. But it is very hard and almost impossible to argue against the data. It takes out the emotional piece of I think, I feel, we believe. If you have data in front of you, as long as that data is empirical and it's accurate, it's that. It's just what it is. You have to look at the data, measure it, change it, but you can't take the emotion piece of it. It eliminates that piece altogether. So a really basic overview, since I know there's a fairly good group on the call, I don't know the level of people, so forgive me if this is a little bit entry, but I think it's worth going over. You have a RIS or a RIS, depending on how you pronounce that, a radiology information system, which is one of the basics. I'll pause, I think that we had an audio blip. PACS, some image management, picture archiving and communication system. One of the keys when you're starting to get into the IT realm of things and something that people watch for, silly little things, never put another S on the end of PACS. There's no such things as PACSes. People tend to put an S on that sometimes, and it's caught quite often by the IT world. So singular S for system. VR, voice recognition. EMR or EHR, your electronic medical record, electronic health record. And then you have ancillary software. You have mammography programs that measure your MQSA and collect your data. You have your AI. You have analytics and post-processing and et cetera. So there's a lot of software out there that we're going to talk about, or at least briefly talk on. We won't get too deep into these, but these are the parts that we're going to go over today. So again, on the basic side, the components of PACS, we have the workstations, the monitors, network, storage, web access. Something that you're hearing a lot more of today is the vendor-neutral archive. What's happened is back when PACS came out, PACS was really devised for the radiology world. It was very unique to the radiology world and locked down. So a lot of your workstations, monitors, they came from proprietary vendors. They were isolated to that vendor only, and you couldn't use them to surf the web or do anything. Well, the web was pretty early in those days anyway. You couldn't use it for much else. Now you have other ologies that are jumping on, and we'll talk about that too because of storage. But that has to now be a vendor-neutral archive that allows other ologies, other departments to access the storage and be able to pull this information back. Cloud technology, more and more embraced as we've come through the years. This is going to be a way to make sure that anyone has access to images or information that is outside of your physical location. Integration and interface, two very specific differences here. Integration basically means something is built within it, so that if you click on a particular button, it launches a program, it's built in, it ties like seamlessly. Interface means they talk to each other, they pass information back and forth. This is two key points that you're going to want to keep in mind. One of the very basic pieces as you're entering into projects that there's the differences of integration and interface. Office equipment is also part of the pack. So you got your reading desks, your chairs, the mouse, the room setup, even down to the paint you use on the walls. If you haven't done a physician reading room design in the past, even to the point where you don't have a satin or semi-gloss finish because it throws a glare off of your monitors if it's behind the doctor. Needs to be something that's a flat and more of a darker color to keep the room dark. Then we have hospital information systems and how they interact with the radiology information system. Your HIS or your EMR are your patient information, your clinical repository. This is where all of your labs, your pathology, orders, reports, and image access stem from. So it's the portal or the gateway to the health system for everything else. What it's getting information and feeding to is the radiology information system. This is where, in the imaging, obviously your technologists are taking these steps because these are going to be measurable data steps down the road. So you want the ability to track the steps in a patient study and how it's progressing. You want to look for areas of improvement. If you keep these stamps and the technologists and the teams are regimented in using them, it's going to point to certain directions, and I'll show you a slide later as to how you can look at areas to improve turnaround times or wait times. So again, the radiology information system helps this. Downstream receiver of ADT or admit discharge transfer information. The RIS system is an end user. It is something that receives information and rarely does it ever send anything back. It may interface back and forth with some information, but this is why when you have an order in the system and it's incorrect, you can't change it in the RIS. It's a downstream feed it receives. Reliant on an EMR for pricing an exam dictionary, same type concept. If you build the exam dictionary in the RIS, well, where it's ordered is in the EMR, they will never match up or they have risk of being corrupt and not being identical files. Analytics, depending on how good your risk system is and how good your staff is and knowing the way to pull analytics out of it, they're going to be very powerful. You're going to have the ability to gain information that helps drive your business, helps make decisions. Number of companies, and one of the ones I'm in now, we use an outside system that we connect to it. So we interface with a third-party system for our analytics. You have your procedure tables, your exam descriptions, CPT codes. Someone needs to be assigned to this to make sure that each year when the CPT codes are updated that somebody's paying attention and that the procedure tables are added properly. When we went through ICD-10, that obviously had a lot of work involved, and we have to make sure that when the EMR is being updated, so is the RIS. If they don't match, they will fail in the crossing over in communication. So very important that you interact with other departments. The IT bridges all of these other ancillary departments together because of the interactions, the interfacing or the integration. A couple of things here, ORD fields refer to mapping, HL7 information, and DICOM modality work list feed. We'll cover a little bit more of that in a moment. This is one of the most important slides we cover because these are two very distinct items within the IT world that will help you in a meeting, because if you speak out in the wrong side of this, you sort of lose some credibility as to understanding what's happening. So DICOM is the Digital Imaging and Communications in Medicine. It was first published in 1993, so it goes way back. DICOM consists of a protocol and agreement on how to communicate. For those of us who have been in PACS long enough, you may remember back in the day where you'd get a disk of images, you'd try and put it into your system and load it up, and you couldn't do it. The images were there, but the DICOM reader was different than the system you had. So they had to come together and talk about how do we come with these standards. So DICOM is one of those standards, and it was initiated by the ACR College of Radiology to address the need for connectivity between imaging equipment. So the DICOM standard is what made so that those viewers could launch in different systems because this was the standard. These two highlighted areas are what I want you to make sure if you have notes or if you're taking notes that you mark this down. DICOM is about the pictures. Remember, it's the Digital Imaging and Communications in Medicine. HL7 is about the words. So anytime you're talking in a group or project meeting and it's about moving images across, viewing images, whether it be through a portal, whether it be through the PACS, a new workstation, a remote workstation, that's DICOM movement. If you're talking about getting information about the patient, the bed update, the imaging report, anything other than images, it's HL7. That's the language it's speaking. Those two are very distinct and will be a big piece of your feeling good about what you're talking about in meetings coming up about these projects. IT standardization. When all this started to come about, it took until about 1998 when they launched the IHE, and that was an initiative to make sure that they try and standardize language across the whole environment. It was very challenging as we talked about the DICOM launching, that images could not come across. People were not using, vendors were not using similar language across their own products and compared to other products as well. So this IHE made sure that we started talking in the same language, which allowed for successful integrations and interfacing. Think about trying to do a handshake electronically when none of the language matched up. So IHE came along and very, very big project and is still ongoing today. So it's fostering that communication between vendors of medical information technology and prove that integration is attainable based on standards. A whole lot of information on this slide, and that's sort of what it feels like when you start diving into the use of analytics and how it can benefit the department. So unbelievable amount of information comes from the information systems, whether it's your risk or a third party. Some of the benefits, you want to be able to control your departmental costs, optimize workforce, optimize utilization of the workforce and equipment, optimize throughput. Saw an audio blip there, sorry. Optimize throughput on your machinery as well as the workflow, billing capture, physician satisfaction, and quality and process improvement. So we'll talk about a few of these. So department costs, if you can use some of the systems, it's not uncommon to have your inventory tied to an analytic system of some sort, an ordering system. You may be barcoding the product you use so it drops into the right amount of inventory and then orders when you need it. So eliminating the overage and cost for storage. Workforce, it certainly gives you the opportunity to look at the throughput of each of your technologists or your ancillary workflow and see where to optimize or where you can do better with even patient placement, throughput of where the patients come and walk through, how patients get to the department and exit, and the throughput. What machine? Every department has a number of machines, and I have not visited a department in probably over 50 hospitals that hasn't had a busy department and a room that's sitting vacant while techs are waiting for one to use because that's the one they prefer. So it's, for whatever reason, it's the layout, it's the design, it's the piece of equipment. They would prefer to wait for a room than take the empty room that wasn't as easy to use. So how do you optimize that throughput? Billing capture, very important. We'll talk about that later as well with MACRA and MIPS. We are now in the point when data and technology that what is not included in your reports can have a financial impact in the negative. And physician satisfaction. We measure a number of things on a daily basis in my current position, and I'll show you some of those examples in a little bit as well. And of course, quality and process improvements. Without data, there's no way to improve, so to measure, to track, and to watch where it grows and changes. So very important in the use of analytics. Some of the drivers in IT and the initiatives. We're back into a radiologist shortage. A number of years ago, probably a couple of decades at this point, it was one of its worst points. And when PACS was emerging, it was really taking the ability to have doctors review and read images in areas where you could not hire. So a lot of change came from that radiologist shortage. The change that came back, the radiologists were good, and we're back into that shortage area again, where they're not as plentiful to be hired. What PACS did is it took small rural hospitals who could not afford to attract local coverage and changed their whole world. Think about some of these small hospitals, some of you on the call might be part of them, where you may have one radiologist and it might even be a struggle to have enough volume to sustain one, let alone two or three. So how do you have one doctor or two that has the scope and breadth of expertise to go from MR musculoskeletal to mammography to cardiac CTs? Just a difficult thing to do because that skill set is no longer as broad as it used to be decades ago. Technology has changed that. So what PACS did is it allowed now the smallest of hospitals to have the same scale of skill set as somebody like the Cleveland Clinic or the Mass Generals or the Cedars-Sinai. So you take these mega systems that have numerous physicians and skill sets, and now they're at the fingertips of any particular practice. And that's sort of the world I'm in today, and that's taking that practice to hospitals, whether they be large or small, and being able to distribute those images to the right doctors. The focus on quality and service was hard to embrace by radiologists. They were more used to the film environment and the throughput environment. So taking them into a digital world and having their quality piece of it a factor in their everyday world was just not what they were used to. So it was a difficult time to embrace, and it took a lot of data to get them to understand and see why it was beneficial. Today, the radiology practices need to demonstrate value to the organization. Many of you might be contracting or going through or recently gone through contracts, and they've changed a great deal over time. Many of the contracts now include what are they offering in value to the organization, whether it be a quality measurement, whether it be meetings that they're presenting. It usually is tied to analytics and what they're presenting to show their turnaround times or their increased quality or reduced or patient wait times. So all this comes from the analytics, and it's often part of the doctor's contracts now. And the doctors needed to learn how to balance quality and quantity. No longer was just quantity the value, because before digital came into the world, it was just as fast as you could read, as much as you could read. And even when there were errors, they weren't easily trackable because they were just on paper, or somebody would have to call it out and they'd have the overread and they'd have to report back. But keeping those manual logs was difficult. And how did you trend? And once you now expand your radiology pool to doctors outside of your own hospital and they're reading potentially from any place in the country or the world, how do you watch and track that quality in the reports? So real difficulty early on, and still a challenge of balancing quality and quantity. We have some doctors that they can read super fast, but is the quality good? And then we have others that have the best quality of all, but the speed is just not there. So how do you blend those two together? And then, of course, as we said, PACS changed everything: the distributed reading, subspecialists, teleradiology, and 24-hour access. PACS was not a big favorite by the referring physicians. For those of you that have been in the industry long enough to know that the file room used to be the gathering point of all the surgeons and the referring doctors in the morning. They'd come through, stop in to see the doctors, review their images, and they had this very personal connection with the doctors. What PACS did was it pushed that in the images up to the floors and basically pushed those doctors, surgeons, and referring doctors away from the department, where they're now looking at their images remotely, sometimes calling in and coming down. They still have that consultative piece, but it's certainly not what it was years ago when they came through the department every day. The radiology access and subspecialty practices are merging together for better coverage. I would think it's hard pressed to have anybody on the call who hasn't been part of some sort of a merge or a acquisition that's taken place. It's just hard to sustain small practices any longer, the subsidies that may go with it, and how do you get that subspecialty? The information and images need to be shared between health systems. That's a challenge. When you have these health systems coming together that have different EMRs, different medical record numbers, those patients may very well cross. You might be locally, geographically close for the patients, but what was once two different health systems are now one, but those systems can't talk together yet because they don't have the same information. So that's not the best for patient care. So having to work on that, and that takes some special IT projects. We know that patient demand has increased for access to their information results. Back a number of years ago, it's very different than today, where you go in for your imaging procedure and your lab or whatever it might be, and your images and or results are available to you at your home computer. So change that world forever. The demand for speed and accuracy. We went from hours to minutes. It actually went from days to hours to minutes. And the margin of error is slim. The requirement, if you're a stroke center, to have a 60-minute from door to needle treatment leaves about, if you split it up equally, about 20 minutes for the radiology department to do their thing from the time they get an image to get it sent over, to get it read and get a report back and called to the doctor for a stroke program. So speed accuracy is incredibly important and not achievable without the infrastructure of IT. ED expectations changed. How often are your CT cases coming from ED, one of the largest volume referrers now? ED for the CT has taken over from plain film as one of the more primary orders. And we'll talk about some of that too, is how that technology has changed. Subspecialty reads we've mentioned, no longer is the general read as applicable. We now have subspecialties for ortho and MSK and neuro and cardiac. It just goes on, and that's the expectation. So it's difficult to keep up with. Hospitals are not making that much money anymore. It used to be where radiology was one of the last profit centers. Now radiology is almost becoming a cost center, and there's subsidies involved. Sometimes the hospitals are paying a subsidy to the radiology group to maintain them and to keep their quality, to keep them servicing. Hospitals are no longer able to support those subsidies in many cases. So it's through IT again that you're going to start distributing images to other doctors. Instead of having 2 doctors sitting on site because you have to cover from 7A to 7P, but that's too many doctors for the amount of volume. Now you can distribute that coverage through other facilities. So through IT, we're looking at eliminating or reducing many of those subsidies. And then the radiologist pay is often changing to include productivity and quality. I'm in the middle of doing that today, changing contracts over where it's a very different world where the doctors, there's a component of their pay that's tied to their quality and tied to their productivity. So you can't be too slow or too fast or too bad at what you're doing. So very, very interesting dynamics, and you all need that data to measure all of this. Back in the early days of the then and now, we had telephone and paper. We went to a RIS. We went a major dictation change from tape to digital and to transcriptionists to editors, if you even have any of those at all. Back in the day, for embracing technology, I think that was probably one of the more difficult ones I went through in my career, and that was getting doctors to go from a transcriptionist typing what they dictated into some sort of a tape mechanism now to being their own editors. But the speed of having a template and a proper voice recognition system well outweighs that loss. It just took a little time for people to embrace it. Obviously went from film to PACS, CR to DR. CMS even today will not pay a certain amount of money on images that are done under CR, and the hospitals are being forced to make a decision. Do you pay the amount of money to go to DR or accept the loss of the CMS payment if it's on a CR piece of equipment, because based on your volume, it might not be financially beneficial to make the change. Storage and disaster recovery continues to be a growing issue. There are so many challenges with other ologies now using the storage. We're going to show a slide in a moment that talks about, we used to be the sole provider of images to that storage cache. Now it's coming from all around, and we are no longer just the largest images or the largest files, but there are some that are even bigger than us. And now they're all going to the same. In disaster recovery, no longer is downtime acceptable. The requirement, if you're looking for a vendor, you should be looking for 99.99% uptime, which is very solid. Voice recognition we talked about. We know a lot of vendors are switching over to EMR and EHR. Epic and Cerner, McKesson, Meditech, there's a number of vendors out there, and it's a major, major project. And when those start coming up, this is when the information we're talking about today is going to be important. VNA, we mentioned before, vendor neutral archive, and that's because everybody is now sending images and they all have to be able to access and see their own, not just radiology. And AI, the AI coming into play now is coming on fast and furious. It's artificial intelligence. If you haven't heard about it yet, or if you're not involved in something, it's coming your way soon. It is being accepted, and later in the slides, we'll see that CMS has actually done its first approval to payment on the use of AI. Common terms and justifications. This is another important slide. If you happen to have notes, circle this one, because these are some of the things that you're going to hear. This is when you get into the meetings and the acronyms are tossed around, or the words are tossed around as if we know what they were. So back when I first started these meetings and I was the radiology manager or director coming into the IT world, these were very, very confusing to me, or just at least foreign. So we all should know the first two here. HL7 is about the words, and DICOM is about the images. You're going to hear the term ORD fields. That's Object Relational Database. The ORD field is all those pieces, like pretend in the RIS system that you're looking at the bed, the name, the date of birth, the notes, the exam order. Those are all fields, and those are a field that has to be mapped across, and you're going to hear that commonly talked about in the meetings. Do we need this field? Can we move this ORD field over here? We need to map them to this particular one. We talked about interface and integration. API is a very common term. That's an application program interface. API is when the doctor sits down at their PACS station and they open up the PACS. They log into PACS, and in the background, their voice recognition system automatically launches. That's an API. That is something that is now taking the handshake, making it an automated program interface to say, with this doctor logging on here, launch this other program. And there could be numerous programs in the background. It could be your post-processing software. It could be the voice recognition software. It could be your AI software. So there's a number of things that would be part of that. Then you have your lightweight directory access protocol. That's the one login for everything. That's when the doctors or the groups want to talk about, when I log in, I don't want to have to log into each individual item. So that's called LDAP, is when you'll hear that term. And they also call it single sign-on. So if you ever hear LDAP or single sign-on, that's what it is. It's that interface or integration, depending on the products, that launches everything from that single sign-on. Then the gateway, you'll commonly hear the term cloverleaf. Cloverleaf is kind of like Kleenex is to facial tissue. They just had a superior product back in the day, so the name cloverleaf became what's called. But it's a gateway. It's a communication pathway for all these other machines to talk to it and then take that information and push it to the other sites. So the gateway or cloverleaf is something you may hear in those meetings. Servers and routing, those should be fairly similar, or familiar, I should say. IP address, you're going to need to know this when you're putting equipment in, when you're hooking up any workstations. Just understand that that address is unique to that piece of equipment, that piece of hardware. And that's going to be things you're going to need to make sure that are collected and gathered, and you're going to want to have a notebook of those for each piece of equipment so that when you call for service, you have these addresses that they know how to access. EMR, HER, we know those acronyms. Templates and macros, those are referring to your voice recognition systems. Very powerful. If the doctors aren't using them today, try and get them to embrace them. If they are, like most practices, about 60% of all imaging is negative studies. And if they have a template or a macro for that, it's as simple as chest x-ray negative for the macro, and it will pull up all of the wording and all the verbiage that is into that and set it up for them to sign. They have a one click and off it goes from the wrist back to the portal into the EHR. So if they're not using them, try to get them encouraged to do so. Mapping, we talked about with the ORD fields. You're going to hear that term quite often. AI, we talked about, and two new ones that I wanted to put up here that keep getting pushed. We have the clinical decision support and the AUC, appropriate use criteria. These are two items that CMS has pushed off yet again. But hopefully that's not foreign to people at this point, and those are items that if you haven't been hearing about them, you should be. After this, if it's something at your hospitals or at your facilities, you should be checking to see if this is even on the radar, because it was supposed to start this year now. It got pushed yet again, I believe, due to the COVID pandemic, so we don't have a start date yet, but IT initiatives should have been well underway for this. The ROIs from the EHR and why and how it matters to get these products and these vendors to provide to you what you're asking. If you're looking at a vendor or a product, let them do that work for you. Tell them to give you the reasonable justification for finances. They'll go ahead and give you a return on investment. They have that already done. You may be careful, don't take the boilerplate they give you, but make sure it applies to you and the parameters are accurate, but they should be able to give you the return on investment information. But the faster turnaround time of reports going out, increase of charges capture, the speed and accuracy, outpatient and inpatient satisfaction, all which will lead to increased market share in a very competitive environment. We all know the market is becoming incredibly competitive. We have billboards up to talk about how long the wait time is in the ED. We have the demand from the ED for turnaround times, and even your referring physicians now. If you are too far behind on the curve and you're not timely on your reports, you're going to find yourself losing to your referral base. A quick little diagram to show the flow of the information. Now this is interfacing and integration depending on which product. You can see that clover leaf in the middle of the picture there. So the HIS sends information to the RIS. So when you register a patient, this is where it gets a little bit complicated, and this is where it can sometimes get a little messy, because most registration systems have the same doctor under multiple names. It's just something that happens. It's in every health system. And then it comes to the RIS and hopefully matches up with the right information in the RIS. The RIS then sends information to the PACS system, so it's stored there waiting for images. The PACS also feeds to the workstation, so it's waiting once the images are in the PACS, it goes to the workstation. Modality gets its information from the RIS. You see that purple line that just came in. So your DICOM modality work list is built from the information based out of the RIS. When you finish your modality, the images go to the PACS system. And then you have the interface between your voice recognition and RIS. So from the workstations, the doctors are dictating and that taking that information back and forth from the RIS and putting those reports back in to the repository. And then that clover leaf is often something in the middle that connects all these different products. Improve patient care and the business need. Why providers care about IT? This is a lot of repeat of what we were talking about, so I'm not going to go through bullet by bullet, but basically your configurable and reliable performance. The uptime is phenomenal. The amount of time that the systems are now in a productive mode are easily in the 99.9%, if not higher. And that's what's expected now. So the physicians are no longer, willing to put up with downtimes of hours on end. If you happen to have them, you'll know it creates quite a bit of chaos because it's just no longer acceptable. Collaboration, flexibility, and scalability, the up and down across all the medical specialties to communicate, to be able to be in your system at a radiologist station, click into the EMR, get your lab values, get the histories and physicals, and get the information you need for your report and the best patient care has just been a huge step forward. And the high availability and data integrity, very limited scheduled downtimes, and often your migration for hardware upgrades is automated nowadays. Just leave the systems on, they update in the background. What's happening in imaging that are changing the world and changing our forces? The acquisitions and consolidations. We talked about that a few moments ago, where we have either mergers, acquisitions, consolidations. These hospitals are coming together. They're having a tough time financially surviving. So they're either being bought or merged or acquired so that they could now leverage what they have from a cost perspective. And that's changing the IT world in a great way. We need to integrate multi-vendor PACS. This is one of the biggest challenges. How do we take a Cerner PACS to an iSight PACS to a McKesson PACS and have them interact with each other? And from a doctor perspective, the referring physician, if you think about their side of it from the patient, they sent the patient to hospital A. Hospital B is still in the same network now. They're now part of one health system. If hospital A and hospital B are different medical record numbers, as we mentioned, that referring physician knows that that patient went to hospital A for a CT chest. They got sent to hospital B for something similar. That exam gets repeated again if you don't know that it was done at hospital A. And that's a very common occurrence because there is no common medical record number. There is vendor software that can help you put those two together. But if you're on disparate systems and numbers, it's a challenge. So archives are also expected to be multimedia. They want to be able to see these in different formats in different places. The medical record numbers we talked about is a challenge. Competing health system for the same patients. You're all in the same geographic area at times, and the pathway that the doctor is going to take to send their patients is the path of least resistance. So who has the fastest way to get the patient in, easiest way to access to that hospital or that clinic, and the fastest return of results so they can get back to their patient who's waiting to hear from it. You need to have cloud accessibility with images within and outside of your health system. That goes back to the hospital A and hospital B scenario. If you're using the cloud, then there is some software and certain products that will access that cloud, and before the doctor dictates, present to them that there are similar images for this patient, even if it's at another hospital. In the cloud, they can then see those images. Very important. It's really the best thing for patient care because we're ending up repeating studies and not having the best histories or priors to compare to, because it could have been just a month later, we could have had changes in the anatomy in those patients. And then they're also looking for a single point of access for all the clinical information. How do they do that? How do we get there? Major, massive projects when you're part of a consolidation or acquisition to make this happen. So a couple of pieces in the tools that we've used then and now. We all recognize that pager down at the bottom left. And now we're to the point where we went from that voice dictation system on the right to having tablets and phones that now have full resolution images to be viewed at the bedside or in an office. We talked about technology and the equipment. If you look back when CT started in the early 70s, the resolution of almost 5 centimeters was common, and now we're down to a 0.1 millimeter. 5 millimeters to a 0.1 millimeter in resolution, and that's in 2000. So we went from single slice to multi-slice. Think of what that does to the amount of data that you're now collecting. So back in the time when that scanner didn't even do a full circle, it did a partial circle and cocked itself back to rescan again and had all that delay. Now that study, which was taking maybe 75 slices for that same exam, which might be a CT chest, might be 300, 400 slices or more based on timing, contrast, and what you're looking for. Huge data files that are now being moved across the network. But at the same time, which something that's really benefited is, look at the reconstruction time. We went back again from the 1970s early on to 2005. We're at decimal points of a second versus seconds to have one image reconstructed. So again, the size of these files is just phenomenally big. We're going to talk about some of the analytics now, billing RFIs, technology productivity, turnaround time. We'll go through some of these. So billing RFIs, what in our particular system, and don't know if everybody has it out there, but somebody's probably looking at this at some point, whether it's electronically or manually, they're looking at the reports to see if they match up for the proper order. And does the report include everything it needs to maximize the capture of your billing charge? So we have systems that are automated. They get run through a scrubber. And what now happens is the reports are kicked back to the doctor to say, we need an addendum on this report, or we have to change the billing. We have to downgrade the exam. So this is money left on the table. This is a huge piece of dollars and cents that is something that's fixable, and it's money that's left on the table if it's not corrected. So that RFI stands for request for information. So what happens is that scrubbing of the report will either show that maybe it was a contrast study and it's missing how much contrast was used or the type of contrast or the pathway. Usually the biggest one is history and physical. Very strong challenge here because we don't control what the history and physical are. The technologist could help by always interviewing that patient and putting their sign or symptom down so the doctor can see it and dictate. But if it's relying just on what's being put into the system, we still see today things like rule out, history of, those will not get that exam paid. So those get kicked back. The doctors have to redictate and put an addendum with the proper reason for exam. Hard to get that when it's usually coming from the floors or the ED. It's a search and destroy mission to go find it. Technology productivity, very important to know who is and what is happening in the department as far as your throughput. Do you need more technologists? Do you need aides? Do you need something to help in the throughput that is also going to maximize the amount of volume that you can do along with your billing capture? Where I work today, turnaround time is king. Everything is based on turnaround times. The second to that, or tied with that, is quality. The quality is certainly always there, but time for that report to get back, we measure that every day. And let me try and get that. Sorry. We measure our turnaround times every day. Radiologist productivity. We look at our RVUs per hour. We build our schedule based on the number of doctors we have, the number of RVUs they read per hour, and then we have productivity and predictive analytics as to our volume. So we look at our volume from month to month, over year to say this evening between midnight and 8 a.m. per hour, I know approximately how many RVUs I'll be getting based on historical data. Then I could look at my schedule of doctors and know this bank of doctors I have on read approximately X amount of RVUs per hour. Does that match up my schedule with what I'm expected to see? So making a schedule is no longer a body in a chair. It's how much does Dr. A read compared to B versus how much volume we're getting in. Quality, as we talked about, is something that the analytics we're always looking at. Peer review is a constant, everyday piece of the workflow. Step-by-step analysis, watching where and when each step of the patient experience is happening and where could you find areas for improvement. What are the turnaround times and the processes for stroke reports, critical findings? How do you track lung screening to make sure that you have that flagged for ACR follow-up? And then we mentioned MACRA and MIPS, which are tied to reimbursement based on your data analytics. This slide is just a couple of examples of what we do, what we look at. Top left corner, this is emergency room, number of procedures in a month for a particular facility. We look at how long it took from the facility from the time the technologist completed the study to the time it was available and ready for us in our system. Then we look at how long it takes to transport and the routing of that image. We time every step of how long it takes for that full image set to come across to us, how long it takes for that radiologist once it's available to read, and then the total end-to-end study. And that's what we measure every day, every hospital, and they expect it. Bottom left corner, simply volume trends. You can see an impact of COVID in this year and then where our volumes came back. Top right corner, this is for those of you in radiology that are dealing with a radiologist, you'll hear the term cherry picking. What happens is, particularly if you have doctors that are on a productivity model, they are looking to read the higher complexity studies because there's more RVUs to that, which usually equates to more money. So you can't have somebody that only reads the high complexity studies and nobody's reading your plain film or your basic information. So what we do is we actually measure the doctor and what % of each study they're reading so that we can measure, watch, and then sort of police what they're doing, because we'll have to talk to those that don't have a good mix. If you look at the very top two lines of that particular grid, you'll see under CR there's only 1% and 2%. So that's someone that we're going to have to sit down and speak with to get more of a ratio up on the plain film to get that read. The bottom right corner is information that we present to our facilities, and this shows the number of studies by patient type, inpatient, outpatient, emergency, the modality, and how long it took. Now, this is only the radiologist hat time, which is at the top left corner, the second last column. That's once the images are actually there for the doctor, how long does it take him to read it? You cannot get any of this without the analytics and the data that you get from the systems. These are just as an example of some of the people that are also, or I should say some of the other services that are using our storage being our facilities, the health systems, no longer just radiology. And some of the largest slides and largest data sets are pathology. The detail that goes into a pathology slide supersedes almost anything we have in our arsenal for the size of storage. So this is where vendor neutral archives need to play. Projects in the EHR, make sure you map out your current flow. Very important. If you don't do some sort of a workflow diagram, you will potentially miss the steps that you're trying to fix, or you'll forget to implement something. So if you don't have Visio, write it down, post-it notes, doesn't matter what you do with it, just get a picture of it, make sure you have it, so that as you're going through the pictures or you're going through your steps, you don't forget any of these boxes, because if you have them in the meeting, they'll be important to remember. Additional considerations in the implementations, particularly with the EHR. For some reason, ED workflow is often overlooked. Some of the simple things, like is the patient bedded before the test is ordered? That's going to have a different location for the patient of where that report's going to go back to or be available for. And it's going to be different on the HL7 information. If it's an ED patient, it would come across to your risk system as ED. If they're bedded, then it might say, bed 234 is where that patient is now coming across this information. So it is important to understand that scenario. Physician databases and security setups. Is your radiologist living in a PACS or risk dictation world? What is their primary piece? Because that's the workflow. Do they open and sit in PACS and that's what they go from, or do they open in the dictation first and select their images from the dictation system, which is integrated with the PACS? You need to know where that workflow is, because it's a difference in how you set things up. The PACS drive scanning of documents, additional software. You're going to need some sort of a DICOM scanner. What are you doing with that piece of paper today? You can't lose it. You need to still keep this information going to the doctors, and you're going to have to test those and make sure you have locations. Lack of PCs, lack of scanners are very easily overlooked, because you're trying to expand your department, and you have to look and see the congestion of your technologist workflow. Make sure that there's enough of these pieces at the beginning, or you start losing that built-in tendency to use the hardware and software. Are your risk and HR vendors the same, or are they separate? Are you looking at a seamless integration, or are you actually going to have people working and mapping these fields over that we talked about earlier and make sure that they're there? And then now we're talking about your LDAP again. If you have two systems, you got to launch one that's going to launch the other. Make sure that there's a formal project plan. Identify your critical paths. If you have project management experience, you'll know what those are. If not, it's basically It is the most important path that has to be completed for everything else to work. And then you need to know what the dependencies are. What is dependent on something else to get done for it to work? Make sure you have a multidisciplinary team. Make sure you're talking through from every aspect. Invite anybody you can from all the departments. They'll peel off as you start talking about it, but make sure they're included in the beginning. Identify your super users and make sure you have a training plan. Who is going to embrace the technology and help the department when the vendor steps away? It's going to be left on your plates, and you need to have someone who is good at technology, is willing and open to it, or is already somewhat of a subject matter expert. Ideally, plan for no disruption to the radiologist workflow. Really step through that. Make sure that anything you're doing that touches the radiologist workflow, whether it be information coming to them, the launching of a PACS image, the dictation, the template, the login, anything at all, make sure that's gone over time with a fine-tooth comb. Test multiple patient orders from end to end. Don't just do 20 chest x-rays. Make sure you have multiple orders. You have combination orders. You have orders that are unique. Look for ones for laterality. Make sure that all of these things come across properly. Make sure you dictate and document downtime processes. You're going to have to break the system to know what it is, or talk about what happens when it breaks, and you're going to have multiple different breakdowns. If it's transmitting of images, that's one thing. Now you have whether you're receiving HL7 information. Is the report not getting back? Is it the native PACS down, or is the modality down? What's happening, and each step should be identified. That downtime probably should be established, documented, communicated, and practiced. And then make sure you test all devices. Often overlooked, careful studying of the physician workflow. Understand how they will change. New orders or prescriptions needed differently. How do they get them today? Imaging order sets. Sometimes the order sets, if they're an older system, they no longer are there. You can order like a panel that has a certain number of exams that explode out from behind that. That's not well accepted today. So if you're in an old system, that might not transfer. Engaging physicians of all specialties to participate in the build. Anybody that's going to receive or be part of imaging, make sure that they have some input. And an opportunity to practice in the live environment. One of the things that I stress when we do our go lives is to make sure that we do a parallel workflow without turning the system on. It's in a test soft live, we call it, so that they do the system in the real environment and they're doing the new system coming up in parallel. It's a little extra work for the techs. We do a handful of studies each day, but it shows where the breakdowns are. At this point is when you really want to break the system or see if it's going to break before you go into the live environment. And you need to hold the team accountable. They should send in and submit how many days they did each day, because if you don't hold it accountable, it's hard to do that when you're in your normal work environment. You're very busy. Collect evidence available when it breaks. Make sure you don't forget your PRN staffing for training, and multiple vendors and generations of equipment means different information is available to interface. It's not a one-fits-all, so make sure that if you're dealing with a Philips and a Cerner and a Siemens, that these are all different in how they talk and go back and forth to your systems. What typically gets missed, step-by-step workflow, testing interfaces, makes the prelims, sometimes they're no longer available. That's a break in the system, that's an expectation. Make sure that's talked about. Billing workflow is super important for your collections, and then just continue to test. A couple of things that we talked about, I'm just gonna come past this slide. Voice recognition we talked about, a little bit different. Comprehending human language falls under a different field of computer science called natural language processing. This changed the world into the macros and templates. Please make sure that this is tested. Make sure this is transferred and the doctors have had a chance to log in. And make sure that what they do is they sometimes lock the system down after they've tested. So when they come back in on live day, their login doesn't work anymore. So make sure you know from the vendor when they've made that system lock and system change, because the last thing that is wanted on day of go live is everybody logging into the system and that login doesn't work that they did during their testing. Make sure for speech recognition you have a radiology engine. I've seen some of these hospitals buy PACS systems that say they have voice recognition. It comes with a office version of voice recognition. It does not have the radiology dictionary. So you're not going to be able to dictate exams because it doesn't know what an oblique is, or it doesn't know what a paracentesis is. These are general office dictionaries. It has to be a radiology voice recognition engine. Talked about shortcuts and standard reports, making sure laterality and gender peer review, there's software for those items as well. Clinical decision support, we mentioned this earlier on. Note that the ordering professional is ultimately responsible for the consultation as their NPI is reported. So what this is, the ordering doctor now has to submit during ordering the justification code that went through the approved CMS software that says this is the right test to order for the right symptom. If that does not come across, you will not be paid as an imaging provider. So this misaligned incentive, because the referring physician is ordering it, is not the one who gets the impact if it's not right. And that's when I said you should be having your sites with discussions about this already taking place. Artificial intelligence, the game changer on everyone's mind. The question is not that it will replace a radiologist, but it will replace the radiologist who does not embrace it. Very important. 5 emerging technologies in 2020 in healthcare informatics. Number 1, artificial intelligence. What is AI? Just gives you a little better. You can look at this. It's a computerized, it's sort of like CAD on steroids. It's taking algorithms and looking at images for discrepancies in what's a standard pattern. And then what's really important about this is the game changer that Medicare is now reimbursing as of September 2020. The first ever reimbursement of a radiology artificial intelligence algorithm was a significant milestone for the industry. So it is here and it's not going away. Some related reading for use of AI and some of this information, please take a look at this. Blockchain, a very brief mention. I know we're coming up to the top of our hour. Blockchain was originally meant for Bitcoins, but it is the idea of having a single patient identifier that would be transferable to any health system anywhere that patient goes in the world. So it's a mechanism that it's emerging, not a lot of traction yet, but they're looking about trying to use this in healthcare. And the keys to successful leadership: expect and appreciate change. Don't expect to be an expert at everything. Develop good decision support skills and involve your teams. Conduct a good needs assessment, workflow, and desired end product. Build a good network for support of all your departments. Understand and respect the stress of computers and information technology has on physician and staff when we're making change, that people are generally technophobic. So a couple articles at the end here show you how serious it is. I'll let those for your reading pleasure at the end, but people have lost their jobs at very high levels when projects have gone bad. We talked about the real life of who owns the data, the report delivery, AE titles, some of the things, just to recap, and most importantly, test, and test. I'm going to turn the camera back on. I have a couple of minutes for some questions. I want to thank you for paying attention today, and thank you for allowing me to be part of your session. And I hope you're all having a great afternoon. So any questions?
Thank you, Ken, so much for that presentation. We do have a few questions that have come in. The first is, can you identify what the difference is between DICOM versus HL7?
Yes, just to do a recap on that, the main part is DICOM is always about the pictures. HL7 is about the words interfacing from one system to another versus sending pictures back and forth. So very key, make sure that's an important piece to acknowledge and remember.
Perfect. Okay, our next question is, what is the importance of diagramming the existing workflow?
It's really important because when you diagram a workflow, each box can have its own whole diagram as part of it. And when you do this diagram, you should pull in a number of people that are involved in it, because they're different people at different aspects of the workflow. If you don't capture those pieces and you're building a new system, if you miss a piece of that workflow that's important, or there's contingencies down the way that if something you don't do step 1, step 2 can't happen, you'll find yourself in a very fast break fix mode. So mapping it out so that you have it reviewed on paper so that you can see it, and then when you build your new flow, you can check off each box to say, yes, we have it covered.
Great, thank you so much, Ken. That is all the time that we have for today. If you did ask a question, please rest assured that those will be sent to Ken for him to address to you individually. Thanks again, Ken, for such a great presentation. As a reminder to our audience, You can obtain your CE certificate by completing the post-webinar survey. The survey will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 CE credit, and you will be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can contact me at webinar@mdpublishing.com. ICE Magazine is proud to bring you our new monthly webinar series to the imaging industry. Thank you for joining our first webinar of 2021. For more information about our upcoming ICE webinars, please visit icewebinars.live. Thank you all and have a great day.
Thank you, everyone.